2018, the clinical grant was awarded to Dr. Aveni Haynes, who is a research fellow at Telethon Kids. The title of her project was using continuous glucose monitoring to characterise early dysglycemia in young children at risk of type 1. So, Aveni, thank you. So, first of all, Aveni, I wonder if you could just give us a little bit of an overview of what the study was, what the aim was, and the sort of technology that you're using.
Okay. So thanks everyone in advance. So my study, before I start on explaining how we've done over the year, I just wanted to, most of you may be familiar with what continuous glucose monitoring is, but I just wanted to give you a little explanation of what that is before I explain what I used it for. So continuous glucose monitoring, often referred to as CGM, basically refers to new and continually advancing technology. So if you look at the diagram, the little module on the bottom with 1 and 2 on it basically contains a sensor which has a little probe that sits just under the skin, and has number 2 is a transmitter. And what the sensor does is it sits under the skin and it can read blood glucose levels every 5 minutes all day for up to 10 days. The number 3 is the different devices. So using Bluetooth technology, so wireless, the transmitter can send those blood glucose readings to a variety of devices. So if this is a patient wearing it, it can go to a phone. If you've got one of the smart fancy watches, it can go to a watch, and it also gets sent to the cloud so clinicians can have a look at it in real time. So it's pretty amazing technology. This is just an example of what a clinician or a patient and a family may look at. So the bottom of the picture shows you the time of day, and along the top you've got the levels of the blood glucose. So the grey band is what would normally be called your normal blood glucose levels. So someone who doesn't have diabetes would hopefully be staying in that, whether they're eating or sleeping, whatever's happening. This trace is probably from someone who has type 1 diabetes or diabetes, because the blue line is the range of blood glucoses. So when we look at traces like this, we can see, well, is the person's blood glucose staying the same the whole day? If they just came in and had a single blood test, it might be normal, but it might be going up after they eat, or it might be going too low at night. So being able to know what the readings are throughout the day gives us a much better idea of what the body is doing and how it's managing its blood glucose levels. So this diagram, sorry, I like my diagrams, is again to explain why we're using this. So my study is actually looking at children who are at risk of type 1 diabetes but haven't developed it yet. So in theory, they should be having normal blood glucose levels all day, and there shouldn't be any variation outside of the normal. But this diagram is trying to show, so really on the side, the beta cell function, they're your cells in your pancreas that make insulin. And what this diagram shows is that over time, which is shown on the bottom, how the amount of beta cells goes down over time. And our understanding of that has improved a lot over the last 10 to 20 years, with people being studied over time before they develop type 1 diabetes. So rather than going down all of a sudden in a straight way, we now think that it goes up and down, and it varies in different people, so it's not the same for everybody. We know that the environment is important, we know that the genes are important, but we also think that this process starts maybe from conception. Definitely pregnancy is important, and then early childhood. So it's not something that just suddenly happens at a specific time before they get the disease. It can start a long time before. And we have what we call stage 1 diabetes now, which is where we know these children have antibodies, which are the sign of the immune system attacking the cells, but they have normal blood glucose. So although they have the antibodies, nothing has changed in the way they're managing. Stage 2 diabetes is where we know they now have the antibodies, but their blood glucose levels are also not working properly, but they don't have any symptoms. If you didn't check, you wouldn't know that anything was amiss until stage 3 diabetes, which is when they would normally have the symptoms we classically associate with diabetes and present to hospital. So my study is trying to learn more about, as well as identify, these children who have the antibodies, so we know they're on their way towards most likely getting diabetes, but we don't know what happens, what means that some of those children could go on to have their blood sugars not working properly. Some might happen quicker than others, and how can we understand that better? So we know that children can have changes in their blood sugars years before they actually develop the clinical signs. So that's what my study was trying and understand. And the study is set within a wider study. It's an Australian study called the Environmental Determinants of Violet Autoimmunity. So we almost have our 1,500 Australian babies now, who we recruit their mums when they're pregnant, and either mum has type 1, dad has type 1, or they have a brother or sister. And then we follow them up during pregnancy every 3 months till they're 2 and onwards. And we're testing them for islet autoantibodies. Sorry, that was just a picture to say that it is all across Australia, and I'm very grateful for your grant because it means I can lead the study from Western Australia, and we have all sorts of hospitals and families involved, including in regional areas. So what we're doing in India is we're measuring these antibodies, and we know from other studies, not particularly India, there's a study called TEDDY, that even children who get type 1 diabetes when they're 15 or older, they actually develop these antibodies, the persistent ones. The peak age is actually between 1 and 2. So in India, we're using these as our primary outcome because we know that those children who have 2 or more antibodies at that age, before the age of 3, have a 75% risk of developing type 1 diabetes in the next 10 years and a 100% lifetime risk of the disease. So essentially, they've got type 1 diabetes just without the glucose changes. And that was just to show you it's very early. It also depends how many antibodies they have. So if they have 2 or more, they have a much greater risk of developing. So in India, we have now 1,497. We've had 900 babies born. The median age is 2. We've still got babies to be born, and the oldest child is 6. But already in India, which started in 2013, we have 13 children who've actually developed clinical type 1 diabetes. Most of them have been about 4. And for my study, we have 23 children who have stage 1. So they have persistent antibodies in that early phase, and these are the children that we're interested in and looking at in these blood sugars. What we're also doing is we're going to look at other children in India who are of a similar age and sex to these children but haven't got any antibodies to try and work out, is there a difference? So it's, I think this study is really important. India is the only study in the world at the moment that is following at these children from pregnancy onwards. So we've got very novel and new information that we'll be able to add to that. We'll be able to look at risk factors during pregnancy and other things we're measuring, including things like the microbiome that you all hear about, in these children, and contribute new knowledge, which will hopefully end up with prevention. So I probably answered all of Joey's questions. I apologise in my nervousness.
No, that's excellent. We like to keep you talking. Can you give us a little feel for how the study's going, and a little bit about what you're seeing, and how you think that as time goes on, you'll be able to use that information? What do people think about it? What do the parents think about it? And how might you see that impacting on people's future risk?
Okay. So one of the things that's been tricky this year is that the new sensor that we're using, which is the Dexcom G6, means that children don't have to finger prick anymore. It's factory calibrated. So normally with these, to kind of test the monitor, the kids have to finger prick twice a day. So at the moment, we haven't, although we've used sensors on some of the participants, it's been the old sensor, the G4. It's only been on a handful of participants, and they probably won't make up this study in the end because we're going to be using the G6. There's several reasons for that. The new version of this, the reason we've waited, I suppose, is that the G6 doesn't get influenced by the use of Panadol, which influences the readings on the older version. The children don't have to have finger pricks, which to me feels like a huge ask to ask these little kids to do twice a day for 2 weeks at a time. And it's more accurate, and it lasts for 10 days as opposed to 7 days. So there's a lot of advantages to the G6. So the traces that we have done using the G4, I think the one thing that we have seen, which surprised me, maybe because I wasn't aware of this, was that they actually seem to go low overnight. So I would have thought they would be going up I don't know why I think that, but they actually seem to go low overnight. And some families, even before this study, actually report that clinically, that they are experiencing, the children are experiencing low blood sugars before they actually develop the clinical symptoms. So I think that's really important. And what I understand that means is that your feedback mechanisms in your body and all the hormones, how they're working, that early hypoglycemia is a sign that that's not working properly anymore. In terms of what I think this is going to mean to the families and what we hope this will do. So in terms of the families, I guess there's several aims. What we find in the NDA families who have got children with islet antibodies, that many of them are really understandably anxious, and many of the mums have told our coordinators they actually finger prick their children anyway. Because if the kid gets sick, they're going, oh my goodness, is this diabetes? And they will finger prick them. They've got someone in the family who already has had type 1 diabetes, so they understand that. So they are very anxious, and we actually ran a little community kind of question group with them because we're asking to put these sensors on very young kids, toddlers, who don't yet have type 1 diabetes. But the majority of the response from the families is that I think they will find that reassuring if they have the traces and they are within normal. In terms of the hypoglycemia, I think that's something clinically we still have to work out. What's a significant hypoglycemia for us to be concerned and to think about, should we be treating it? How do we teach the families whether they should be treating it or not? The other main thing that has come out of some of the other longitudinal studies similar to India is that these participants, there's two, I suppose, benefits of being in these sorts of studies. One is that we hope by using this that we'll detect these children before they develop the clinical signs. Hopefully, by being part of the study and doing this, we might be able to initiate early treatment. And we now know that the beta cells, the amount that are left at the time they start having their insulin therapy, is important for the longer course of the disease in these patients. So if we can pick them up early, perhaps we can start the insulin early and preserve some of those beta cells. And I guess the big thing is to prevent diabetic ketoacidosis, which is a severe onset. I've got one more slide to show you about, I guess, another dream, but we'll let Joey ask a question.
You kind of alluded to this along the way, but just in terms of the funding from DRWA to support this study in the context of a big Australia-wide study, how important has that been? Well, and then maybe you can give us your little dream.
Okay. Well, I feel very humbled and incredibly grateful to have received this grant. There was the first kind of big grant, that wasn't a travel grant or a little prize that I've received. And I really do feel that it makes a huge difference to people like me that are early in their journey for research to be able to lead a study which, even on a global stage, I think is going to contribute really important findings. An example is I've been invited to be part of the JDRF International CGM in Prevention Working Group. So the reach will be much wider than Western Australia, but being able to lead that here and build our team and our capacity here, I think makes the world of difference. I couldn't do this study if I hadn't got the grant yet. And I guess the dream was just, in case any of you aren't across this, so there's a lot of progress and discussion in the field of type 1 diabetes and prevention, which is the ultimate aim. And there was a study through TrialNet, which was published earlier this year, and the results presented, which was the first study in my couple of decades working in this space, which was actually shown to be able to prevent and delay type 1 diabetes in children at risk. So that's super exciting. And we are linked in with TrialNet, and if we can identify these children early, perhaps that will be a future for them where we can try and delay, if not prevent it.
Fantastic. Awesome. Thank you, Aveni. I might open up to the audience if there are any questions.
Just picking up on the Panadol, why does Panadol and how much cause their blood sugar to rise?
So my understanding is it's to do, so I think the sensor that sits in there, I don't know the chemistry very well, but it's to do with oxidation. And I think there's something to do with the Panadol that interferes with that makes the sensor reading higher than what it actually is. So I think they've changed that chemistry in the new sensor so that the Panadol won't interfere. We've been collecting whether they're sick or taking Panadol to make sure that we can take that into account, but it's not as much of an issue. Yeah.
wanted to check with you. You're doing it with parents who have type 1 already. Did you say you're also doing it with some children who don't have a family history of it?
So this study is all the children will have a first degree relative, so mum, dad or brother or sister. I totally agree with you because most people in the population who get type 1 diabetes don't actually have a first degree relative with type 1 diabetes. So these findings may not necessarily translate across. The reason that I think all of these studies actually are either based on genetics or a family history is just because type 1 diabetes is relatively rare. If we were to go to the general population, we might not get enough to be able to make any meaningful conclusions or comparisons. So that's a main reason why I guess it was structured like that. Yeah.
Thank you, Dr. Haynes. My question was very similar to that, and maybe to the adult population, following them even further if they don't develop type 1 at an adolescent age or something, following them later, or is there any implications for further research in that area?
I think that's a really important question because we've already seen there's quite variable patterns in the islet autoimmunity. Some children we actually will get a blood test where it comes up and then it disappears. What's different about them? Some only get one and that just carries on when we know they have a much lower risk than those who get more than two. So without a doubt, there's different subtypes of type 1 diabetes. I think at the moment we are waiting on confirmation or hopefully renewal of our funding from JDRF, who are funding the bigger India study to follow these children up to the age of 10. So I agree. I think ideally we would want to keep following them up because they will be a different subtype. Yeah.
Fantastic. Well, thank you very much. Congratulations again. We look forward to the